Trend and outcome in the cardiogenic shock management. The prevalence of cardiogenic shock is stable, but its prognosis has seen little improvement over the decade. Despite many therapeutic advances, the in-hospital mortality remain high, which is about 40 to 60%. Recently, there is a trend, steady trend in increase in perioperative use of short-term mechanical circulatory support in a patient with a cardiogenic shock bridge to durable ventricular assist device or orthotopic heart transplant. Evidence to support indication of MCS device, the timing of implantations and selection of the patients and devices is scarce. So as I said, in the national trend and overall, the trend is, this short-term MCS use is in a rise, and similar trend we seeing here also in our center. And if you look at it, the first two, third and fourth, which is I'm comparing between the tandem and Impella use. Over time, the purple one, the tandem use is slowly going down, and almost similar to the gray, the Impella uses in our center. And the last year, first time, the Impella and the tandem was equal. Also, look at the balloon pump uses is also the balloon pump uses is also coming down, which is a similar trend everywhere else. So while we're talking, I'm going to skip a lot of slides. So what are the available devices and or strategy for the short-term MCS? So intra-aortic balloon pump, you have left atrial to aorta assist device, which is currently only left atrial aorta assist device is tandem heart. Left ventricle to aorta assist device, which is Impella, which is currently FDA approved. Another one is going in the trial. And you have a VA ECMO. My talk is mainly focused in a surgical Impella, which is a 5.0. We're not going to talk about the LD here. The Impella 5.0 is a 9 French catheter-based device. The motor is about 21 French. So a significant bigger size. So anytime when we implanting this device, we need a vascular access. Vascular access in terms of we have to connect the graft to the artery and deploy the device. Either you can use a femoral artery or you can use other alternative site. Most commonly being used is the subclavian arteries, and especially the right subclavian artery. When you deploy this device through the femoral artery to the graft, it defeats the purpose of this. The best thing you can do with this device is the mobility, which we can achieve, which you cannot achieve with other similar devices, which is a tandem balloon pump ECMO. Well, ECMO you can do, subclavian, but in terms of the short circuit device, it's Impella will give you the best in terms of the mobility. So our preferred approach in our center is it's a right subclavian artery. Just give you an anatomy in terms of when we implanting and taking care of this patient post-operatively in terms of the complication related with the surgical implantation. And the most site to be implant, as you look at the first part of the axillary artery, which I call sometimes subclavian, but Dr. Rajagopal says, no, it's truly axillary artery. If you look at the pec minor muscle, beyond the pec minor muscle, that's where the most time we implanted. That's where you're not going to have many branches, and the nerve bundle, which is a risk of injury when you're implanting, will be the lateral side of the artery. Also, when you have a minimal venous tributaries, except you're going to have a cephalic vein. So surgical technique, what involves? Remember, this patient has to have it's a subacute situation. You cannot have an ongoing CPR patient, and I can put a 5.0. Remember, you have to have this patient taken to the operating room. So we needed some time. Patient will be, majority of time, yes, you can do local sedation, but preferably do it under the general anesthesia. So site of incision most commonly is below and parallel to clavicle and the deltopectoral groove. We divide the pec major muscles in direction of his fiber, expose the clavipectoral fascia. At that point, you're going to have a pec minor muscle. Now, two things you can do. Either you can divide it, or you can just retract it. What I feel that dividing is the problem is, and as soon as you divide it, you're going to have all this nerve branches going to come up in your way, which is going to come under, and it risk of injuring. So easy thing, just retract it, and you're going to have a thoracoacromial branch, and that's a nice point of the insertion side. You can extend the incision and anastomose either 8 or 10 millimeter graft. Then you can do with 8 millimeter graft, which is going to give you about 24 French. Once you anastomose the graft after deploying, and then either you do it by yourself, or in the base case, in our case, our cardiology colleague is always behind us to help us out to pass through the aortic valve and deploy the Impella. So complication, what should be caution? I did not want to put as a disadvantage. I said, and initially I thought I'm going to say disadvantage of doing this procedure, but I would say more caution. Number one, remember, it's a time consuming. You're going to need at least a couple hours. Even you go fastest to put a deployment, this device, it's a time consuming. Number two, brachial plexus injury is real. If it happens, your patient's going to have a significant, motor function deficit. Number three, consider it as a vascular injury, not only when you're deploying it, also when you're explanting these devices, you're going to have a vascular injury on some time. And infection is a risk. You're putting a graft which can have outside access. So try to put this graft as much as, inside the tissue. Leave not any graft tissue outside, because that's going to extend your infection if your Impella is going to stay more than a week or 2 weeks, which is approved for only the week, though. Now, how do we take this out? Let's say this patient is breached to a transplant or devices. The best way to take this device out, in our experience, what I found, take this patient, open the chest, make sure you're ready to cannulate, or if you cannulate the patient, and then take the graft out. Before you take the Impella out, get the access, get those vascular control. As like any other device we're going to take out from any other vessel, you're going to do proximal distal control. Two things can happen. There is always a clot in those graft, because the graft, you have the residual, the flow stasis. When the device goes through it, there will be always some clot. And if those clot, it's hard to just remove by just doing a thrombectomy. Get a distal control to prevent embolization. Second thing, also prevents a long-term infection. Always plan, once you take it out, take the entire section out, all those clot tissue, and either you can staple it. Sometime it's very hard with a vascular staple in a morbidly obese patient because it's very deep. In a thin patient, it's going to be easy. It's going to be in your face. You can take it out. Otherwise, suture through double-layer Prolene suture. So what is our experience at the ECTAT? Total so far, we implanted, we have a 21 patient with the 5.0, which is, I would say, within the last year and a half to 2 years. We implanted 17. We attempted axillary implant on a 2 patient. One patient just directly was not so unstable. As I mentioned, this patient needs a time when we go there. So this patient just went on an ECMO because patient decompensated very rapidly, did not have a chance, ended up on an ECMO. Back. Where is it? I skipped a lot of. Oh, there we go. It was like it's the end of the talk. Okay. Well, I'm gonna skip a lot of stuff. So, and one of our patients, we went in the OR, but we prepared to that also. We very morbidly obese patient tried to implant. We had an axillary graft and unable to pass. Now, the Impella is the motor pump is about 21 French. Some of the patient between the first rib and the subclavian, when you have a hard time, sometimes passing this motor through and they keep bending, And I think they're coming with the nice 5.5 with the, the motor is going to be small. But still some patient has a problem. We ended up putting an auxiliary balloon pump on one patient. And another patient not able to do that, so we have to put a graft in the femoral artery. And we ended up putting in a femoral artery, and I just wanted to show my, our result. Now, out of 17, we put 16, in at least 9 of was an acute cardiogenic shock CPR patient which was placed. Everybody died eventually. Now, granted, every patient had either ECMO or Impella CP came outside. The good result we saw in the selected patient, which we were compensated, I would say intermix class 2 patient or 3 patient, which became a little bit stable with inotropic support, who went on to the 5.0, one able to go to direct transplant, one able to go to the, 2 patient able to go to bridge to, 3 patient LVAD, 1 patient like bridge to transplant, LVAD, and they're doing well. So conclusion, so if I have to select this patient in the short-term devices, Impella 5.0 is a good device in a selected patient. Now you need to choose as your institution, a right patient and a right timing is always a key. And remember, don't keep these devices to prolonged time. Infection is a major complication too. So if you're planning to breeze them early within 2 weeks. Thank you.
Thank you.